What is it that makes them so sick in the first place? What is that? That science has really emerged in the past and present tense. It is with us, it's sitting at the table, and it's called the science of studying social determinants of health. And the term coined for it are social comorbidities. Like 5 years ago, very few people would know to string those two words together, social comorbidities. Harvard School of Public Health went so far as to say, and everybody buys it, no one disputes it, housing is healthcare. And they went one step further and said, with the Institute of Medicine, the World Health Organization, and the Department of Health and Human Services endorsing their comment, they wrote this paper together, that your zip code is more determinant of your health care than your genetic code. So we're in a very different era, because this is stuff that people in the behavioral health and social services arena have known for a long time. How can you expect someone living below the poverty line, unstable housing, a victim of domestic violence, grew up with alcoholic parents, they were traumatized here, how in the world can you expect them to be healthy? So we've known that, because we work in the field, but now everybody gets it. And they get it in part because the science has caught up to what we knew sort of intrinsically, but also because it's mandated. So they can't refute this because it's in their contract, right? So their opinion might be that's bunk. People are responsible for their own health care. But their contracts say, thou shalt address social determinants of health. Thou shalt address housing, transportation, child care. All of these things that we've known are barriers to wellness. And then the other is to get to that value-based reimbursement is tremendous transparency, where we're going to be able to see into the performance of these health systems at a very nitty-gritty level, and people, consumers, are going to be urged to shop around. And a lot of providers don't like that because they don't score very well, but too bad. Done deal. It's in the law, and there are websites all over the country. Every state has one. California's got several, that you can go online and see the performance of our hospital systems, our medical groups, our surgical groups, primary care physicians, and behavioral health providers are coming soon. So all that outcomes data, quality data that you have is going to be public. So every time you have someone who should have been in a program 90 days but was only there 30 days, people are going to know. And that'll be on the basis upon which they're shopping for services. So we want people to be consumers, educated and informed. So those are important trends that I'm hoping, and I'll stop here to see if there are any questions. And this reshapes our reality in a way that it hasn't been reshaped before. Yeah.
This is huge. I can see a lot of people, fighting all kinds of battles to try and resist it. I mean, first one that comes to mind is insurance companies. If you replace Kaiser, say, take Arizona, they won't let Kaiser in there, okay? If you flew Kaiser in there, there's going to be a lot of insurance companies that are going to see their bottom line go substantially down, if not to zero. So, I wonder if this is a bunch of ivory tower Harvard guys' wish list of what they'd like to see this become, and no one's really figured out what kind of battles are going to be waged. Let's not talk about the desirability. I'm looking at it from the standpoint of this organization and moving too fast or too slow.
Yeah, you're behind by about 3 years. So this train left the station 3 years ago, and the health insurance companies are making bank.
I know that, yeah.
They love it.
Yeah.
And what we haven't gotten over, though, which I think to your point, is the state line issue.
Yes.
So health insurance can't cross state lines.
I know.
So that's still preserved, but every other aspect of this, the creating these joint venture organized delivery systems that are having to develop community-based systems of care and focus on all this stuff is in play today.
How does that translate into bringing costs down? Because, just an example, years ago, I got in a biking accident, and I got my bill from UCSF, right? And when you looked at the itemized things, it was insane what they were charging for gauze and what they were charging. Do you know what I'm saying? So how, to me, that was a crime. So how does that, in this structure, how does that prevent it from happening? Because those are the people that should be getting fined.
Right. So what happens is, if you go back and the mechanics of this are so complicated, but the reason why hospitals and doctors charge so much is the very, very complex reason. It has to do with the levels of deductibles, it has to do with the contracts they've negotiated, whether or not they can balance bill, what their fee schedules are, their agreements with the health insurers, and how much of what the health insurance company's not gonna pay for can I get you to pay for out of pocket. So they artificially, and having been a provider, I mean, I've seen both sides of this, they artificially inflate their price so that a roll of gauze is $180.
Yeah, it's $200.
Right? Yeah.
No, you're totally right.
Tylenol's $25 for one
Yeah.
Tylenol. They do that on purpose because the spread between what the insurer's gonna pay them and what they're not gonna pay them, they can then count that as a loss. That's a loss. So now I have an accounting reason to do that, because every time I lose money, that helps me sort of protect my profits, right? So understanding how losses work, but I can also balance bill. Some of my contracts allow me to balance bill. So your insurance company is gonna pay $8 for a $28 thing. So here's a bill for $20. Now I'm gonna try to get $20 out of you, but let's be fair, I can't get 20, so I'll take 10. And now you feel like you got a deal. Oh, okay, I got a deal. At least I talked me down to 10. And they have vast, they've got a farm of people in cubicles who are just negotiating deals like that with you.
Yeah.
We understand 20 is too much. Can you pay 10? Yeah, I can pay 10. I feel like they did me a favor. I still paid $10 for an 80-cent roll of
Now you're
gauze.
making me feel bad, because I got them down to half. And they did it so easily, and I thought, geez.
But what happens
God.
here is so fundamentally different because the provider and the payer become one. So we won't be saying words like provider and payer 10 years from now. Because if I asked you to describe Kaiser, you'd stop and say, well, there's sort of, your head sort of has to do this kind of rearrangement. They're like a insurance company that's the provider. They're
Oh, I
both.
never thought about that. I didn't think about it.
They are.
That's right.
So the tension that exists goes away, and now the hospital is saying, wait a second, don't use that roll of gauze. There's a half-used one over here that's clean, it's sterile, and we're at risk because we're the payer. So now instead of opening a new roll of gauze, let's use this half-used sterile roll and save ourselves some money. Can you imagine? Like, it's a whole different paradigm. You don't need the MRI, right? You don't need the MRI. You might be asking for an MRI, but the hospital, who has heretofore always wanted to give you an MRI, right? Oh, they love MRIs, and CAT scans are even better because it's just volume-based model. Let's keep giving them, and well, I already had that lab taken last week. Well, we didn't get the results, so I'm going to take it again. All that goes away because now the hospital is at risk. The whole of that integrated delivery system is at risk. So everyone's going to be counting their pennies and saying, do you really need to use the van to take one person to that appointment across town Do you guys provide transportation? Okay? So you're gonna start, in this era, you're gonna have people saying, can't you take 3 or 4 people? Can you schedule things so that it's more efficient? Because we're paying for that. We're not gonna get paid for it, we're paying for it. So it's a very different, whereas today you might say, well, shoot, every time we take the van out, we get paid 85 cents a mile or whatever. So keep taking it out, and we're gonna make more money. It's a different paradigm. When you take and graft onto each other the providers and the payer, the distinction goes away and you've got a completely different business model. Completely different. And it invites then all these questions. Do we, if that circus tent is gonna go up in Marin, do we wanna be under the circus tent and playing with everybody? Or do we wanna take our chances and stay outside the circus tent? And what are the risks and rewards associated with each move? And that's what we'll continue to talk about. I included just a little definition about social comorbidities, more so to keep you guys abreast of what's going on, to help you explain to yourselves and to your staff and to anybody else who might be wondering, what the heck is a social comorbidity? And it really goes to the fact that living under duress, under stress, the stress of homelessness and poverty, the stress of violence in the home or the community, produces disease. It doesn't just exacerbate it, it actually produces it. And this is not Patrick's opinion. This is all scientifically validated stuff, that if I'm living under stress for a long time, I release cortisol and adrenaline, right? Cortisol activates cardiovascular output. If you have unmitigated cardiovascular output, you're going to develop hypertension. You can also develop diabetes independent of whatever it is you're eating. Diabetes, obesity, hypertension, heart disease, cancers, not to mention the fact that the more cortisol and adrenaline you've got flowing through you over long periods of time, the less this part of your brain works. This part of your brain is working all the time. What they call the reptilian brainstem, right? So you're always acting out of instinct, fight or flight. So if you look at, I live in Los Angeles, and you go onto Skid Row, and people are basically operating on a fight or flight, or they're stoned out of their minds, because they're tired of acting on a fight or flight basis.
Just for those of you who are not members of Kaiser, any time you go to Kaiser these days, whether alone or with your significant other, they will ask you if you feel safe at home.
Yes.
Every time. You may not even realize it, but they ask me every time, do you feel safe? Not just women, they ask men, do you feel safe at home?
And they're starting to ask about drinking patterns.
Oh, they
Oh,
ask
they
that too.
always ask
Yeah.
that.
Yeah, the
Yeah.
doctors in general have.
They always ask how
Shy
many
away
drinks
from-
do you have a week, a month, whatever.
This idea of value, we were talking about upstairs, what is value, how do you define value? So I've given you a sense, this is a very light touch sketch of the kinds of things that they're measuring to determine value. And what I want you to see in here is yourselves. And this, whenever I do this kind of thing, I'm trying to give you a mirror so you can see what it is you have that you're bringing to the dance. And if it's prevention, wellness, the integration of behavioral health, that, and if I go back a slide or two ago, remember, 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 and we're going to look at it in the next slide. Integration of behavioral health into the circus tent is a requirement across Medicare, Medi-Cal, and now private health insurance. They have to.
So that's what you meant, that we are desirable and we have leverage?
Yes.
Because that aspect is mandated by what we would call the big tech providers.
Exactly. So it's like if we were doing a mathematical equation, number one, We have to be integrated. Now, is it gonna be us, or is it gonna be some other shop down the street? Because there is, and we were talking about speed to market is a factor. Because if it can be us, but we sit on our hands for another couple of years, somebody else may get that seat at the table. Because the circus tent is not gonna have an infinite number of providers in it, right? They're gonna reach a point where they say, we're good, we're done. We've created our network, we're happy with it, and and then remember, joint venture, right? So they're gonna sign agreements and they're gonna create a new entity, and they're off to the races. And this has been going on for 3 years. That's why it's like, this is, at one time was Ivory Tower, and now when we get into looking at what's happening in California today, you're gonna see that, holy crap, we gotta move. And move might just be make a decision. I'm not suggesting that I know what's right for you, that you move here, but you need to start making some decisions about what you're gonna move into. Because the opportunity to move is not gonna be a forever kind of deal. This is a very unique window of opportunity. So what's happening with our Medi-Cal 2020 waiver? There's one aspect of it called Prime that, in the interest of time, you can look into, but the more important thing is the second bullet, and that is global payment. Global payment goes back to what I was saying before about value-based reimbursement. The provider system, that big tent, is gonna get paid a global payment. A global payment is one lump sum, a really big lump sum, for each of the people who have that constellation of chronic conditions, okay? And they know actuarially that the people who meet certain characteristics, not high blood pressure, heart disease, diabetes, major depression, okay? Typical constellation. These are the folks we're gonna focus on because we know actuarially, we've studied all the claims, and it's the people who have those 3 things in common that cost us this much. And this much is $100,000 per person per year, actuarially speaking. Lots of averages and weighted and a mean and lots of heavy duty stats.